Good morning to each and every one of you who has joined. Um, my name is Ashok Agrawal. I am the Director of Research in the Global Andrology Forum, which is part of Global Andrology Foundation. And today we have a very exciting program, which is what I will be introducing in the next few minutes. It's a online educational program that we have created, and I will just go through the various elements of the program. This program has been organized with the collaboration of Dr. Aziz Bek, who is representing various societies from Uzbekistan, and we are very pleased with his support and for his request to create this program for his urologist and andrologist and doctors, as well as from many other parts of countries in the region, as well as around the world. As of this morning, and this number has changed, we have about 370 is the current number or tally of people who have registered. And this is the breakdown from the Google form that we have. The largest number of those who have signed off or signed in for this program are from Uzbekistan and Russia, as well as Kyrgyzstan and so many other countries, as you can see. The breakdown in terms of those who are attending mainly are urologists and andrologists. As you can see, about 70% of them are urologists and andrologists. And then there is a mix of those who are medical student residents and others. So this is a fantastic group of those who are attending the program today. The program is really structured to provide some important information on the latest um, issues in the area of male reproduction, both infertility as well as erectile dysfunction. So we are going to discuss important topics on both aspects of male infertility and male sexual dysfunction. Our first speaker will be Dr. Rossella Canarella from Italy, and she is going to talk about antioxidants and their role in male infertility. So she is going to provide an evidence-based presentation which will handle many of your questions that you are looking for. Dr. Vidi Atmoko from Indonesia is going to talk about premature ejaculation and its current management strategies. Further, Dr. Marlon Martinez from Philippines, a rising urologist and andrologist, is going to be talking about varicocele and male infertility in an evidence-based presentation, which will be fantastic. The last presentation is of Dr. Mohammed Noman from Yemen, who is going to be talking about organic erectile function and explaining this important topic in a way that will be very interesting. But in addition to that, the main conductor of this orchestra is Dr. Rupin Shah. As you can see here, he is going to be the moderator and managing this program towards the end. I want to thank my colleague Dr. Hiva Alipur for managing this webcasting. He has been really helpful in organizing this program and in helping in creating many of our flyers along with Dr. Ms. Daniela. So I want to thank him for his valuable time. I also want to thank Daniela Delgacillo, sorry, who's our research coordinator for her help. She's really the foundation of everything that we are trying to do. So we cannot thank her enough for her help. At the end of the program, those who complete the program and fill out the satisfaction survey will receive a certificate of attendance, which will be similar to that with their name imprinted, which will be beautiful. And they can save that and print it. It will be a beautiful PDF format. Now, let me jump directly as an introduction to the Global Andrology Forum. And many of you probably have not heard of it, as about half of those who are joining today, or maybe more, are not members of GAF or Global Andrology Forum. So let me just quickly describe what is the Global Andrology Forum. We started about three and a half years ago. It now includes about 870 participants from 95 countries. And bulk of those are andrologists, neurologists, uroandrologists, as well as IVF specialists, embryologists, geneticists, and so forth. And our mission is essentially to produce rigorous, high quality research in infertility and sexual medicine. And that is being done and to lead global education and methodology driven training. Our vision is to build a truly global collaborative network of clinicians and researchers and shape the future of andrology by bringing together the most committed experts from around the world to drive innovation, integrity, and impact. And this is a breakdown of the number of our colleagues who are members of our foundation from many parts of the current world. And this is the breakdown in terms of the number from who these people are by their profession, as you can see. And this is also available in a publication that we have published. These are our people in the Brain Trust. These are the people who advise the direction of what we are doing. These are leaders from all parts of the world, and they have distinguished themselves in the field, and that is why they have been selected as advisors. So we have all these people who are guiding us on a day-to-day basis. Our main philosophy is really the underlying philosophy is the mentorship is the highest form of scholarship. And this is a snapshot of our organization, structure, functional teams, and communication lines. And this is also available for someone who wishes to read more about us in the publication which has been published, and you can find it in the PubMed. And this is how we divide our roles and duties. It's a virtual program. The truth about research is it's really not so simple. If it was simple, everybody could have done it. It is a lot of hard work. I mean, we should be really truthful, but by working together in a collaborative manner, we can really do wonderful things. We are using the digital means, digital tools to really run this program where we have various types of tools that are commonly available to everyone. Those are the ones that we are using to drive our research. This is a virtual research where the advances in computational technology is really changing the things that are being done. So really, for a lot of the research that we are conducting, we don't need traditional laboratory equipment or physical facilities. We really use our digital means to conduct complicated advanced research such as meta-analysis and global surveys. This is our productivity in just 36 months. We have produced more than 145 peer-reviewed publications, many books, and contributed to global guidelines, clinical guideline. And this is a exponential shift in scientific output. And this is just a snapshot of our work. It cannot be captured in one slide. So the Global Andrology Forum is really a world united by science. And we really are dependent on each other. And our main motto is that quality is not an act, it is a habit. So without the mark of excellence, whatever is being done is not good enough. So I think we really strive to do our level best. One can become a GAF member by going to you can search us on the Google as globalandrologyforum.com, and there is an application that you can fill in. Everything is free. So membership is free, training is free, participation in various events is free. So thank you very much to everyone for listening to us and for attending this program, which will begin immediately after this. So I will ask the first speaker now to go ahead and share their presentation.
Hi, everyone. Can you see my presentation?
Yeah, we can see it and hear it very well. Yeah, great.
It could be okay, wonderful. So first of all, it's a great honor for me to be here, and I thank you all of you for attending this program, as well as the organizer for asking me to join this wonderful program. So in the next 15 minutes, I'll try to give you small overview uh, you know the antioxidant therapy in male infertility. So this is a field where a lot of research has been published. But if you look at the society's recommendations, you will see that not all the societies agree regarding, if we should or not use antioxidant for the treatment of male infertility. Therefore, we will try in this journey to try to understand why there is this differences in opinions, and what should be the evidence-based approach to treat our patients. First of all, what is the background? So we are talking about the use of antioxidants to treat male infertility. We know that male infertility is increasing in terms of its epidemiology, and I wanted to share with you all with this pie chart. This pie chart basically is from the Italian Ministry of Health, and basically it's a picture of all the data of all the Italian IVF units. And basically, it describes the etiology of couple infertility, of the couples undergoing to IVF. And this is very interesting to me because if you look at the female factors of infertility, you will understand exactly what's going on. So how many female partners are reduced ovarian reserve, how many tubal factor, and so on. But if you look at male factor infertility, you don't know at all if the male factor infertility is due to male accessory gland infection, or hypogonadism, or testicular cancer, or varicocele. And this is underlie something that is not typical of Italy. This is a worldwide approach that has historical reasons, and we don't have time to describe this. But basically, the infertile male is underdiagnosed. We do not follow overall a comprehensive diagnostic approach to diagnose the cause of male infertility. And if we don't know the reason for male infertility, we cannot prescribe a evidence-based treatment. And this is one of the reasons why we strive so much to understand if we should or not prescribe antioxidants. We don't have clinically, majority of male do not go through evidence-based diagnostic approach. And this is one of the reasons I like of GAF, because GAF try to understand and to teach what should be an evidence-based diagnostic approach of male infertility. So why antioxidants should be used for male infertility? The reason is that if you look at the sperm is a very particular cell. It is ultra specialized if we compare it to the other cells of our body, and specifically it has the lowest amount of cytoplasm compared to all the other somatic cells. This means that the scavenger activity of the sperm is very, very low. So the number of antioxidant enzymes within the cytoplasm is low, given the overall quantity of cytoplasm that is low. And this means that the sperm is very, very sensitive to oxidative stress. And as you can see from this cartoon, a lot of disease or factors can increase the amount of oxidative stress to which the sperm is exposed to. For example, known causes of male infertility, so diseases like male accessory gland infections or inflammation or varicocele, or disease like cancer in general, or even lifestyles factors like smoking, use of drugs, or the exposure to pollution. So in this, within this background, it becomes important the use of antioxidants, because antioxidants can, improve the capability of the sperm to counteract the increase of oxidative stress. Something that I want to mention before we move forward and to review the literature and the evidence about this topic is that if in the sperm there is a reason, a cause basically, that is increasing oxidative stress, for example, varicocele, or an infection, a bacterial infection, if we give antioxidants, the sperm will be subjected chronically to the oxidative stress from, for example, the bacteria. The literature says that we first need basically to remove the cause of the increase in oxidative stress. Then the prescription in antioxidant can counteract the oxidative stress and then can improve sperm parameters. That said, let's review the evidences. So to avoid to respect the time that I have for this presentation, I have removed some of the meta-analysis that I wanted to present. And so I will review with you all the Cochrane meta-analysis and then our meta-analysis, the GAF one. So first of all, something that you will find in the title of this meta-analysis is antioxidants for male subfertility, which is interesting. It is not for male idiopathic infertility, it's for male subfertility. This means that if you review all the articles that have been included in this Cochrane meta-analysis, basically they did not evaluate basically the impact of antioxidants in male that underwent to a diagnostic algorithm. They just assessed the impact of antioxidants in male with infertility. And this is, again, highlight the first point that we showed in this presentation, the fact that we don't do usually, evidence-based diagnostic and comprehensive approach of the real cause of male infertility. So this is the first thing that represent a source of heterogeneity that will that is statistically present in all the plots of this meta-analysis. Something that is important of this study is that the live birth rate, which is the most important clinical outcome that we look for, is the first outcome of this meta-analysis. The secondary outcomes are clinical pregnancy rate and the adverse events, and finally the sperm parameters. Something that we need to understand, however, is that live birth rate, clinical pregnancy rate, and miscarriage rate depends also on the female partner, of course, while the sperm parameters depends only on the male one. So while the author says that they included 90 randomized controlled trials, about 2/3 of them were included in the plots and were analyzed. So overall, we have about 60 randomized controlled trials that have been meta-analyzed. Because the other 25, to be precise, the other 25 did not have extractable data. So this is important to understand this. So a total of 10,000 infertile patients, which is noteworthy. And another thing that is important to highlight is that for the primary outcome, which is the live birth rate, only 12 studies among the 19 randomized control trials that the author claimed that I've included only 12 analyze the live birth rate. So that said, this is the plot of the study. So you find basically that the odds ratio is 1.43. So this means that the overall the use of antioxidants showed to improve statistically the live birth rate. Of course, the limitation is due to the reducing number, of course, of patients that have been included. So we have less than 700 patients and less than 600 controls, but I mean, this is what we have. But another thing that I want to show you from this plot is that if the authors did something that was interesting, that they, when we talk about antioxidants, the molecules that we the drugs basically the nutraceutical that we prescribe usually are a combination of mixed type of molecules at different dosage. So what the authors did in this plot was to basically try to analyze each specific combination. Basically, for example, you find astaxanthin and vitamin E, or carnitine or vitamin E alone, and finally combined antioxidants. And the final message is that you cannot recommend one among a specific antioxidant formulation or a specific dosage, because the literature basically is not large enough to recommend a specific basically dosage of formulation. The only thing that we can say is that overall the antioxidants that have been administered, so no matter the formulation and the dosage basically showed an improvement in live birth rate. The same was found for the clinical pregnancy rate, but in this case the number of studies is higher, and also the odds ratio is higher, 1.89. So the improvement in clinical pregnancy is twofold higher basically compared to those that did not receive antioxidants. No risk of miscarriage. Only 6 studies were included though, and this is another important thing. Regarding the sperm DNA fragmentation, interestingly, there wasn't a significant effect on sperm DNA fragmentation. That is something that we reported in our meta-analysis as well. Regarding the sperm parameters, there was no effect on sperm concentration, while there was an improvement in sperm progressive motility and in total motility, which is compatible basically with what we would expect from the treatment with antioxidant. And in this cartoon, basically, you find the sub-analysis of each and every compound that was used in the studies, in the randomized control trials that were included in Cochrane meta-analysis. And you find basically that for carnitine and for vitamin E and for the combined basically prescription, you find an improvement in both sperm concentration, motility, and total motility. So these are the conclusion of the Cochrane meta-analysis. Overall, there is an improvement of live birth rate and of the clinical pregnancy rate. There is a heterogeneity of all the forest plot. Indeed, the conclusion of the author is that this is of low quality of evidence. There is no increased miscarriage rate, no change in sperm DNA fragmentation, and there is an improvement in sperm progressive and total motility. Let's move to our meta-analysis. In this meta-analysis, for each study that was included, we carefully, and this is provided in a supplementary table, we carefully included all the factors that were studied in the males that were included, basically. So we included all the inclusion and exclusion criteria of the men of the male factor in order to be sure to include basically patients with idiopathic male infertility, and exclude those that had that were not studied basically for infection. So we included a total of 45 randomized controlled trials, but all the 45 were subjected to data extractions. And while the Cochrane extracted both the IVF live births and spontaneous live births, we focused only on the spontaneous live birth in this study. Basically, we confirmed that the use of antioxidants improve the spontaneous pregnancy rate, and the odds ratio is comparable to what was found by the Cochrane. And we confirmed also the improvement in live birth rate, as confirmed also by the Cochrane. Similarly, there was no significant increase in the miscarriage rate. And we found also an improvement in all the conventional sperm parameters. There was no improvement in sperm DNA fragmentation, similar to what was found by the Cochrane, but something that is additional to what was studied by the Cochrane meta-analysis is that we focused on also on the total antioxidant capacity and on the MDA concentration. And we found that the antioxidants were able to significantly improve these parameters that we know are markers, basically, of antioxidant stress to which the sperm is exposed to. So I'm going to the end of this presentation. So let's move to the recommendation. So basically, what do the societies recommend to us? This is something that came from the European Academy of Andrology. It was published in 2018. Basically, there was no evidence about the recommendation of prescribing or not antioxidants. So basically, this society does not take any position. Regarding the AUA-ESRM, again, they suggest to inform the patients that there are not reliable data. So basically, they do not suggest to prescribe antioxidants because their impact, their utility is questionable, basically. This is an Italian recommendation. Basically, this is interesting because they recommend against treatment to all infertile men, but they suggest to consider the treatment basically to those that have an idiopathic oligozoospermia or asthenozoospermia. And finally, this is the recommendation from the GAF that has been published in this January, basically, which reflect closely the findings from our meta-analysis and from the Cochrane one. So basically, the antioxidants should not be prescribed to all the infertile men, but also to those with idiopathic infertility, basically. The treatment length should be of 3 to 6 months, and the treatment is expected to improve the sperm parameters and the pregnancy rate. So these are my conclusion. And so basically, antioxidants seem to improve the clinical pregnancy rate and the oxidative stress levels, as well as conventional sperm parameters. Level of evidence is not high, basically, before of the study design of the randomized clinical trials that have been designed so far. But it is important that we prescribe these drugs to those that have been studied, basically, where have a comprehensive diagnostic follow-up and assessment has been done. And in those with idiopathic increase in oxidative stress, then there is a benefit of antioxidant prescription. Thank you so much for your attention.
Thank you, Dr. Rosella, for an excellent presentation, unlocking the secrets of antioxidant, whether it is to be used or not to be used. Please hold on the questions for Dr. Rosella. This will be at the end of all the speakers. We have 3 more exciting talks. And now the second talk is by Dr. Vidi at Moko from Indonesia. Dr. Vidi, please go ahead and share your presentation.
Yeah. Can you see my slides?
Yes, go ahead.
Oh, so good evening, everyone. So it's an honor for me to be here today, and I would like to express my gratitude to the committee and also the Global Andrology Foundation for the kind invitation. And my name is Widya, and today I will presenting about the premature ejaculation and its current management strategies. So I have no potential conflict of interest to disclose. So as we all know that the diagnosis of the premature ejaculations require the three aspects. So the first one is a significant distress. Second one is a poor ejaculatory control, and the third one is the reduced ejaculatory latency, which is commonly measured using the IELTS. So the first challenge is that the different IELTS cutoff have been adopted by society guidelines ranging from the 1 until 3 minutes. So similarly, in our previous survey of more than 200 Gulf experts' opinions also varied greatly. So therefore, to simplify the diagnosis, we reached the following consensus that the for research and the clinical trial settings, a strict IELTS cutoff based on the ISSF definition can be used. But however, in the routine clinical practice, the diagnosis will likely require the individualized clinical judgment. So not only that, there are additional challenges in the routine premature ejaculation diagnosis. The first is of all men with the subjective complaint of the PE, only 30% may be clinically significant. And however, the PE is associated with the substantial distress, which was related to the sexual intercourse satisfaction and also the interpersonal difficulties. And the last, the most significant challenge is that the men with the PE very rarely to consult with their physician due to the various reasons, including not wanting to take the pills and afraid of the dependency, and also to consider that it is a natural part of the aging. So therefore, the important first step is by asking the right questions. So when asking the patients, we should aim for three things: to characterizing the triad and also to identify the comorbidities and also to characterize the PE subtype. So on the right side, there are several questions that can help in the diagnosis. So one aspect that may be missed is the assessment of the erectile function. So in the patients with the ED, we should also ask whether they rush the intercourse to prevent the loss of the erections, and the reasoning will be discussed later. And however, these questions may not fully address the distress and also the perceived control aspect of the premature ejaculation. So therefore, some tools such as the PEDT and also the IPE were designed to help in diagnosis. So when asking, when we do the history taking is leaning more towards the acquired PE, we should also assess the common comorbidities. So one study had concluded that in up to 96% of the acquired PE patients, they had at least one comorbidity. So the top three reasons were depression, the chronic prostatitis, and also the erectile dysfunction. Unfortunately, the most of these comorbidities are potentially treatable. The evidence had shown that the direct treatment of the ED, the hyperthyroidism, and also the chronic prostatitis significantly improved the PE symptoms by the various measurement. So accordingly, when acquired a PE is present, shown by a clear reduction from previously normal ejaculatory latency, our experts recommended that if an underlying cause is identified, the premature ejaculation may be cured when that cause is treated appropriately. So before starting the treatment, we should also have a clear picture of what truly matters in the premature ejaculation patient management. So in a study which analyzes the various factors of the premature ejaculation using the path analysis, so we know that the term of the perceived control is found to be a central mediator of the premature ejaculations, so which affects the sexual intercourse satisfaction and the personal distress and also the interpersonal difficulty. However, the perceived control is also influenced by the IELTS. But the IELTS effect on the premature ejaculation management is therefore mainly mediated by its effect on the perceived control. So the message that I would like to convey from this slide is that the goal of the premature ejaculation treatment is never to treat the IELTS duration alone. And sufficiently, we can know that the pharmacotherapy alone will not sufficiently address all of the mentions of the PE. So we can reduce the ejaculatory to increase the ejaculatory latency by the pharmacotherapy and also the topical anesthesia. But also for the perceived control, we can increase by do the counseling and the behavioral therapy and also the psychotherapy for the cognitive distortions. So before the starting the treatment, counseling about the realistic expectation is also important. So in one study, the median IELTS in men without the premature ejaculation was approximately 7 minutes. However, the individuals with the premature ejaculation perceive normal IELTS as approximately 14 minutes and expected treatment to achieve for 15 minutes. So therefore, counseling should address these unrealistic expectations by emphasizing that the goal is a satisfying and also the controllable latency with the realistic IELTS improvement. So the following algorithm may help guide the treatment selection. So the first, we should distinguish the true premature ejaculation from the premature ejaculation like ejaculatory dysfunctions, as the latter usually requires the reassurance, the behavioral therapy, or psychotherapy. In acquired PE, the secondary comorbidities should be treated first. So if no clear cause is found, we can do the behavioral therapy or psychotherapy may be prioritized with the pharmacotherapy or combination therapy used when we need it. And for lifelong PE, usually the pharmacotherapy is often prioritized because the central neurotransmitter dysregulation is thought to play the important role in this kind of the type of the PE. And finally, the gradual drug withdrawal may be attempted after 6 to 8 weeks, particularly in acquired PE. So for concurrent the PE and also the erectile dysfunction, there is a unique vicious cycle. Some men with the ED may fear losing their erection and leading them to rush intercourse, so which can contribute to the PE. So this may increase the performance anxiety and further worsening the erectile function and also ultimately leading to the erectile dysfunction. So therefore, when the erectile dysfunction is present, the PDE5 inhibitors are the preferred first-line treatment. And they are not the PE-specific drugs in men with the normal erections and may be useful in those anxious about losing their erections. And a meta-analysis showed that the PDE5 inhibitors may improve the IELTS by up to 2 minutes versus the placebo, and while the PDE5 inhibitor and also the SSRI combination therapy may add approximately 1.5 minutes versus the SSRI alone. And therefore, GAF has recommended that the ED should be treated first, as this may resolve the both of the erectile dysfunction and also the premature ejaculation. And for the pharmacotherapy, this table summarizes the various on-demand and also the daily SSRI available worldwide. So we should note that the most of the SSRIs used for PE are off-label. So daily SSRI also generally produce a greater IELTS improvement than the on-demand treatment. But it may cause reduced sexual desire and also the erectile dysfunction, which can be undesirable for men with the premature ejaculation. And therefore, we at the GAF believe that the on-demand depoxitin should be used as the first-line therapy because it has a fewer side effects, although it is less effective than long-acting SSRI, and daily paroxetine may be considered in patients who desire the greatest ejaculatory delay. However, it is associated with the higher discontinuation due to the adverse events and takes to 5 until 10 days to 8 and reaches maximal efficacy after 2 to 3 weeks. And long-acting SSRI also require tapering before discontinuations, and so patients should be advised to avoid the sudden stopping by themselves. And overall, the treatment choice should be individualized. So the on-demand SSRI may be best for men with the predictable sexual activity, a preference to avoid the daily medication, and also a realistic expectation about the IELTS improvement. In contrast, daily SSRI should be reserved for men who desire the greatest ejaculatory delay. So we can see that the dapoxetin is it's on-demand SRI. They can do the direct activation of the 5-HT1B and also the 5-HT2C, and also with the daily SSRI, they can do the desensitization of the 5-HT1A. But usually the adverse effects is usually the common is the nausea and also dizziness and the headache and diarrhea, and sometimes it can induce the hypotension also. And the tramadol may be also be used for the PE. It is used as the on-demand medication and can produce up to 7-fold increase in the IELT. However, it remains off the label despite being recommended as a second or third line treatment in the major guidelines. Its use should be approached with caution precaution because of the risk of the opioid addiction, the abuse, and also dependence. And it is also be avoided in patients taking SSRI and also the other antidepressants. So therefore, the GAF consensus is that the tramadol should be reserved for the patients who do not respond to other pharmacotherapeutic options. So lastly, about the alpha blockers have also been used for the premature ejaculation. So the meta-analysis have been shown that approximately 2-minute increase in the ILT, although they may also be associated with the reduced ejaculatory volume. The American Urology Association recommends the alpha blocker as a second-line treatment, although they should mainly be considered in the patients with the concomitant LUTS or those unresponsive to the other treatments, as the evidence remains limited. The topical anesthetics such as the lidocaine and also the prilocaine have also been used, and one limitation is that the medications may be transferred to the partner, and the patient should be advised to apply the treatment only to the glands approximately 5 minutes before the sexual intercourse, and the penis should then be washed thoroughly before the intercourse, and a condom may be used, although not all condoms are appropriate. So, for example, one brand of the meter dose anesthetic spray should not be used with the polyurethane condoms. And therefore, the GAF consensus also recommends the topical anesthetic with the special precautions to avoid the complete penile anesthesia and transfer of the medication to the partner. So the behavioral therapy should also be considered, and several techniques are available, including the stop-start and also the squeezing techniques, and this is the sensate focus and also the pelvic floor muscle training. So in short, the current evidence for the behavioral monotherapy remains inconclusive. However, when we added this kind of treatment to the drug treatment, it may improve the IELTS by up to 1 minute. So therefore, the behavioral therapy can be recommended to patients with the premature ejaculations, and patients may be advised to practice solo and then gradually to progress to the involve the partner. So the final treatment options is psychotherapy. So this is especially important because the premature ejaculation is often associated with the cognitive distortions, including all or nothing thinking and the overgeneralization, the fortune telling, and also the catastrophing and also the mind reading. So the psychotherapy has been shown to be effective when combined with the SSRI. So therefore, if factors such as the performance anxiety and also the cognitive distortions are present, the referral to a psychosexual therapist should be considered. However, if the major depression or maybe there is a severe anxiety is present, the referral to a psychiatrist is more appropriate. So the GAF consensus recommends that the combination of the therapy with the psychosexual therapy should be considered in patients with the refractory of the premature ejaculations. So lastly, in the patients with the refractory premature ejaculations, a stepwise approach may be used. So the first one is diagnosis, and the premature ejaculation subtype should first be reassessed. And this should be followed by a review of the treatment adherence, the dose, the timing before in the intercourse, and also the patient, the expectations. And if the treatment has been used appropriately, so the clinician should evaluate for the missed comorbidities. So if no contributing factor is identified, the combination therapy may be considered. And for the persistent refractory cases, the referral for the newer or maybe the experimental treatment options may be considered. So some emerging investigational therapies are also present, including the new short-acting SSRI and also the oxytocin receptor antagonist. So for the procedural treatments, the newer approaches such as the Botox injections into the bulbous spongiosum muscles have been shown to improve the premature ejaculation, although the efficacy appears to decline after during the follow-up. And lastly, the gland penis augmentation using the hyaluronic acid may be also considered, but as it acts as the physical spacer between the epithelium and also the nerve endings. So to conclude, in the PE management, we should first identify the premature ejaculation subtype and also to treat the irreversible causes when they're present. And treatment should be individualized, and combination therapy may be provide the best and also the most durable outcomes. And lastly, the emerging and also the invasive therapies remains investigational and also should be reserved for the selected refractory cases. I think that's all for me. Thank you very much.
Thank you, Dr. Vidi, for your excellent presentation on premature ejaculation. We really appreciate that. Our next presentation is by Dr. Marlon Martinez from Philippines. Please proceed, Dr. Marlon.
So good day, everyone. So I'll be presenting varicocele and male infertility. So the objectives of this presentation is to discuss the pathophysiology and mechanism of varicocele-related infertility, to discuss how we evaluate and manage these men with varicoceles, to discuss the impact of varicocele on sperm production, sperm DNA fragmentation, and the hormones, and the outcomes on assisted reproduction, and discuss some controversial scenarios. And also, we want to discuss some current guidelines available on the management of men with varicoceles. There are several guidelines that are available, this collaborative effort by the American Urological Association and the American Society for Reproductive Medicine and from the European Association of Urology. And just recently, the Global Andrology Forum published these clinical guidelines on the management of infertile men with varicoceles. This composed of 31 statements and recommendations scored by 24 experts. So as you all know, varicocele is the abnormal dilatation of the pumpiniform plexuses, and this can be present in about 40% in men suffering with primary infertility and about 80% in men suffering with secondary infertility. And when we have varicoceles, it can lead to increase in intratesticular temperature. It can lead to testicular hypoxia and disruption of blood-testis barrier. All these factors can lead to oxidative stress, which can lead to cellular dysfunction affecting the Leydig cells and their Sertoli cells, leading to decreased testosterone production and decreased spermatogenesis. And the initial diagnosis is based on the clinical findings during a physical examination. However, there are instances that physical examination is inconclusive or equivocal. In that instance, we can request for a scrotal Doppler ultrasound. However, based on guidelines, clinicians should not routinely perform scrotal ultrasound in the initial evaluation of these infertile men. So according to GAF, you can request for a scrotal ultrasound if your physical examination is equivocal, when there is thick scrotum or spermatic cord, and the presence of venous reflux with a duration of more than 2 seconds, or venous diameter of more than 3 millimeter should be considered diagnostic of a significant varicoceles. And varicocele may cause progressive testicular damage because I mentioned earlier, it can affect the function of your Leydig cells and Sertoli cells, leading to low testosterone production and abnormal spermatogenesis. And there's several indications when do we offer surgical treatment. According to several guidelines, we can offer surgical management in those infertile men with palpable varicoceles with abnormal semen parameters, or varicocelectomy can also be considered in men with elevated sperm DNA fragmentation, with otherwise unexplained infertility, or those who suffered from failure of assisted reproduction, including recurrent pregnancy loss, failure of embryogenesis, and implantation. So according to GAF, varicocelectomy can be offered to infertile men with clinical varicocele with normal conventional sperm parameters and elevated sperm DNA fragmentation with or without failed IUI or IVF. And there are several treatment options we can offer in men suffering with varicoceles. We can offer laparoscopy, microsurgical technique, embolization. Among these treatment options, microsurgery offers the greatest improvement in conventional sperm parameters with the least complication rates. And in this global practice survey by the GAF, the effect of varicocelectomy on men with poor reproductive potential remains controversial. And it will be helpful to determine which set of patients would benefit most from varicocele repair and target repair efforts at those individuals. In this survey, about more than 60% of the respondents agreed that the result of varicocelectomy for male infertility are controversial. So what is now the role of varicocelectomy in men with subclinical varicoceles? So in this systematic review and meta-analysis, those patients with subclinical varicoceles who underwent varicocelectomy, there was improvement in the forward progressive sperm motility. However, there was no significant difference in the pregnancy in the control group and those patients who underwent varicocelectomy. There's still issue in patients with left clinical varicocele and those with right subclinical varicocele. In this meta-analysis of randomized controlled trials, those patients who underwent bilateral varicocelectomy, there was significant improvement in progressive sperm motility and normal sperm morphology. In men who underwent bilateral varicocelectomy, there was a higher spontaneous pregnancy rate compared to those men who underwent unilateral varicocelectomy. So according to several guidelines, clinicians should not recommend varicocelectomy for men with non-palpable varicoceles detected solely by imaging, and response to varicocelectomy is greater in infertile men with higher grade varicoceles than in infertile men with small varicoceles. So there's still also controversy in the medical literature in set of patients with right subclinical varicocele and left subclinical varicocele. In the event that clinician would offer bilateral varicocelectomy, it should be a shared decision between the surgeon and the patient with the understanding that the benefit of doing bilateral varicocelectomy is uncertain. What is now the role of varicocelectomy in men with non-obstructive azoospermia? So in this systematic review and meta-analysis, in the setting of non-obstructive azoospermia, those patients who underwent varicocelectomy, they had significantly higher sperm retrieval rate, increased likelihood of sperm appearance in the ejaculate, and significantly greater clinical pregnancy rate with ICSI. According to guidelines, clinicians should inform couples of the absence of the definitive evidence supporting varicocelectomy prior to surgical sperm retrieval with assisted reproduction. However, some meta-analysis have suggested that varicocelectomy is associated with the appearance of sperm in the ejaculate in men with non-obstructive azoospermia. So according to GAF, varicocelectomy should not be routinely offered to men with azoospermia. However, in selected cases of non-obstructive azoospermia, those men with normal reproductive hormones, those with normal testicular volume, those with favorable histological diagnosis, like in men with late maturation arrest or hyperspermatogenesis, or if there is no genetic abnormalities, we can offer varicocelectomy. However, further well-designed control studies are needed to arrive at a definite conclusion on the role of varicocelectomy in the setting of non-obstructive azoospermia. What is now the role of varicocelectomy, particularly in men with advanced paternal age? So in this study, patients who are younger than 40-year-old and older than 40-year-old who underwent varicocelectomy, there was no significant difference in the improvement of the sperm parameters and reproductive outcome. And in this study, those patients who are older than 40-year-old who underwent surgery compared to the control group, those patients who underwent surgery, there was significant increase of the spontaneous pregnancy rate. In another study, patients who underwent varicocelectomy, whether they are younger or older than 40-year-old, there was no significant difference on the pregnancy rate. So advanced paternal age is not a factor in deciding whether to repair clinical varicocele in infertile men. And still, female age is the most significant predictor of achieving spontaneous pregnancy or IVF success and should be considered while planning the management of infertile men suffering with varicoceles. So according to GAF, in couples where the man is infertile and the female partner is older than 35-year-old who wish to conceive naturally, varicocelectomy can be offered as a viable treatment option after consideration of the female factors like the age and counseling about assisted reproduction options. What is now the role of varicocelectomy in men with elevated sperm DNA fragmentation? So patients with varicocele, they have significantly higher sperm DNA fragmentation compared to control group with the mean difference of more than 9%. So according to GAF, SDF testing may be considered in those patients with clinical varicoceles, even with normal semen parameters. And performing sperm DNA fragmentation testing will assist in decision-making regarding the value of varicocelectomy and may help with appropriate counseling and management of these infertile men suffering from varicocele. So in this systematic review and meta-analysis, patients who underwent varicocelectomy, this was associated with a significant reduction of the sperm DNA fragmentation rate with a mean difference of about 7.23%. So according to GAF, in men with clinical varicocele and normal semen parameters, surgical repair of varicocele can be offered if the sperm DNA fragmentation is elevated. And varicocelectomy should be offered after diagnosis to lower or reduce the sperm DNA fragmentation for both natural and assisted conception. And as you all know, varicoceles on infertility may be, the effect of varicoceles may be reversed by varicocelectomy with elevated sperm DNA fragmentation. But varicocelectomy may be offered to infertile men with clinical varicocele, normal sperm parameters, and elevated sperm DNA fragmentation. This should be a shared decision between the patient and the clinician regarding the potential benefit of varicocelectomy. So what is now the role of varicocelectomy on the outcomes of assisted reproduction? So in this earlier study about on the failure of fertilization in IVF, so those patients who underwent varicocelectomy, there was increase in the fertilization rate and pregnancy rate. In this landmark study by Mary Samplaski, they categorized patients who are candidate for natural pregnancy, candidate for IUI, and candidate for IVF. In those patients who underwent varicocelectomy, about 57% of patients who were initially candidate for IUI are now candidate for natural pregnancy, and about 21% of patients who were initially candidate for IVF are now candidate for IUI, and about 31% of patients who were initially candidate for IVF are now candidate for natural pregnancy. So in this systematic review and meta-analysis, for IUI, patients who underwent varicocelectomy, there was so significant clinical difference on the pregnancy rate. But for ICSI, those patients who underwent varicocelectomy, there was significant increase in the fertilization rate, clinical pregnancy rate, and live birth rate. So when do we offer varicocelectomy? When do we offer assisted reproduction? So we offer surgical repair of varicoceles in those couple with no female factor. Those couple who can wait for 3 to 6 months or longer for improvement after surgery. For those, goal is to improve the chance of natural conception. So we offer assisted reproduction in those with female factors, like advanced reproductive age, older female patients, those with tubal obstruction, those with severe endometriosis, and those with poor ovarian reserve. And there's a presence of severe male factor infertility. So varicocele or varicocelectomy may possibly impact reproductive outcome for couples undergoing ICSI, and the recommendation for varicocelectomy should be individualized based on the sperm DNA fragmentation level, prior assisted reproduction failure, the age of the female partner, and their reproductive potential. What is now the role of varicocelectomy on the reproductive hormones? So in this systematic review and meta-analysis, men with varicoceles, they have significantly lower testosterone level with a significantly higher FSH and LH level. So in this study, those patients who underwent the serum testosterone of those patients who underwent varicocelectomy improved by more than 30 nanogram per deciliter. So in this another study, systematic review and meta-analysis, serum total testosterone level were significantly higher after varicocelectomy compared to both pre-treatment levels and unrepaired varicoceles. So the treatment of varicoceles can significantly increase the testosterone level and reduce serum FSH and LH level. But varicocelectomy solely for increasing the testosterone level in hypogonadal men is still controversial. What are now the predictors of a successful varicocelectomy? So going back to this study by GAF, the greatest improvement in semen parameters and the greater chance of natural conception after surgical repair of varicocele may be expected in those coupled with young female partner, those with mild to moderate abnormalities of the semen parameters on initial semen analysis, those patients with large varicoceles, those with bilateral varicoceles, those with normal size testis, normal FSH level, and those with secondary infertility. So for my take-home messages, varicocele is still considered as one of the most common causes of poor male reproductive potential. And diagnosis is based on the physical examination, although imaging like the scrotal ultrasound may be used in certain instances. And as we all know, varicocele has a detrimental effect on the semen parameters and resulting to poor reproductive outcomes. And varicocelectomy can address some typical and extended indication for surgical repair. And microsurgical technique offers the greatest improvement in semen parameters and reproductive outcome. However, beside of this, there's still controversies existing on the diagnosis and treatment of men with varicoceles. So the GAF clinical guidelines on the management of these infertile men suffering with varicocele point out the pivotal importance of varicocele in modern andrology, and continued research is crucial to improving diagnostic accuracy and treated outcomes, ultimately enhancing the reproductive health of men with varicoceles. Therefore, the current guidelines allow clinicians to develop effective management strategies for a common issue and address practical questions where evidence is lacking. So this will be my last slide. Thank you for listening, and thank you once again to Global Andrology Forum for this great opportunity.
Thank you, Dr. Marlon, for such a fantastic presentation. You did a great job. I was very, very clear. And now I would like to invite our fourth and final speaker, Dr. Mohammed Noman. Please go ahead, Dr. Noman.
Can you hear me? Can you see my slides?
Yes, very well.
Okay. Good day. Welcome, everyone. I'm very pleased to be with you today. In this distinguished scientific meeting organized by the unique and wonderful foundation, Global Andrology Forum and Foundation. My lecture will be about organic erectile dysfunction from a clinical perspective, and I hope it will be beneficial for all. So I have nothing to disclose, and this is my agenda. The objective of this lecture is intentionally practical. The focus is not on extensive details, but on what clinicians can immediately apply in practice. So what is an erection? It is a complex phenomenon including vascular events, which is mediated by neurological stimuli and influenced by hormonal and psychological factors. Erectile dysfunction is a persistent inability to obtain and or maintain an erection sufficient for satisfactory sexual intercourse. It may be organic, psychogenic, or combined. Organic ED is often multifactorial rather than attributable to a single cause, while vasculogenic disease is the most common etiological metabolic endocrine, neurological, structural, or benign and systemic diseases frequently coexist. Identifying these contributing factors is essential for proper diagnosis and effective management. These conditions frequently coexist and contribute to erectile dysfunction through overlapping biological pathways, through shared mechanisms, including endothelial dysfunction, chronic inflammation, and reduced nitric oxide activity. So why organic ED matters? For many patients, ED may be the first symptom that brings them into contact with healthcare services and may suggest an underlying systemic disease like cardiovascular disease. ED is a common worldwide condition. It has a significant impact on the quality of life, may be a signal for cardiovascular and metabolic disease and often precedes cardiovascular events by several years. So ED is considered a risk marker or a predictor for underlying cardiovascular disease and other health conditions. The EAU and AUA and Princeton consensus documents describe ED as an early marker and an independent predictor of cardiovascular disease. And they considered it as a sentinel symptom of systemic vascular disease. It is important to know the difference between a risk factor and a risk marker. A risk factor increases the probability of a disease because it contributes to its development. For example, diabetes mellitus, which is considered as a risk factor for erectile dysfunction. So it drives the disease. While a risk marker identifies people at increased risk, but may not itself be the cause. For example, erectile dysfunction is considered as a risk marker or an indicator or a predictor, so it signals the risk. Risk factors for organic erectile dysfunctions includes hypertension, hyperglycemia, hyperlipidemia, harmful habits, hypogonadism, and harmful lifestyle factors, and high aging. So aging is also listed here, although it is a non-modifiable biological process, and it is considered as a risk marker, but I put it here for educational purposes. So I call these factors the 7 H's, risk factors, for easy memorization. So please, you can memorize this for daily clinical practice. An important distinction is that erectile dysfunction is linked to cardiovascular disease, but not in all men. The association is strong in men aged 40 to 60 with new onset vasculogenic ED and cardiometabolic risk factors, whereas it is weak in younger men with psychogenic, neurogenic, medication-induced, or post-surgical, post-traumatic ED. So clinicians should not underestimate the erectile dysfunction complaint. The evaluation of ED, like all diseases, requires proper history taking, proper general and local examination, and proper investigations. A careful, detailed history remains the cornerstone of preliminary diagnosis, often identifying causes without advanced testing. Analyze the complaint properly. Take care that you may misdiagnose premature ejaculation as erectile dysfunction. Assess sexual desire. Ask about fertility desire. That is, if fertility is desired, use HCG instead of testosterone injections in cases of hypogonadism. So this table can differentiate between psychogenic and organic erectile dysfunctions, and I call it the initial screening table. You will analyze the erectile dysfunction complaint. Is it acute or gradual, situational or global, intermittent or progressive? Are the morning erections and nocturnal erections rigid or poor? Is there a long history of psychosocial problems before the ED? The 7 H's are often present in organic ED. And I hope you remember what are the 7 H's. So you can consider this table whenever you are dealing with erectile dysfunction cases. Don't forget the possible comorbidity between erectile dysfunction and premature ejaculation. The objective of the investigation is not to order extensive laboratory panels, but to detect the type and severity of ED and to identify reversible causes and assess cardiometabolic risk. So start by ordering blood sugar, lipid profile, and total testosterone, plus minus prolactin. Request other hormones as needed. You can request also intracorporeal injections, ICI, penile duplex, and Regiscan according to the case. It is recommended to order total testosterone, not free, in the early morning, and if it is low or borderline, request another sample. If the 2 samples are discrepant, request a 3rd sample test. It is better not to be ordered during acute illness. PDE5 inhibitors remain the first-line treatment. If PDE5 fails, you can shift to other options like ICI, vacuum erection devices, or intraurethral arbrosadil. If all fails, then you can proceed to the more invasive option, which is a penile prosthesis. And again, please don't forget to correct and control the underlying factors. And if you need, you can do sexual therapy. Now, this slide is very important, and this step is crucial to treatment success. Without it, outcomes may be suboptimal, and therapy is effective today may lose efficacy over time as underlying risk factors or diseases progress. So this is very important to do a lifestyle modification to control diabetes mellitus and to do replacement whenever possible for hormones and modulation of therapeutic drugs. To practice this lifestyle modification, proper ED evaluation and control of underlying risk factors, you will need a multidisciplinary teamwork, such as cardiologist, endocrinologist, nutrition specialist, psychologist, and primary care physician. So now I will mention some important practical points regarding PDE5 inhibitors. It is to be noted that all PDE5 inhibitors have shown significant efficacy and proven safety. Do PDE5 inhibitors cause cardiac disease or heart attack? This is an important topic. Many patients will ask you this question during your practice or even by your colleagues in the same or different specialty. Do PDE5 inhibitors have an impact on the heart? The short answer is no. Large clinical trials have shown no increase in myocardial infarction or cardiovascular mortality. It is safe in patients with stable coronary artery disease, and it is safe in men receiving antihypertensive medications, including those taking multiple antihypertensive agents. Also, it improves vascular parameters and indicate the potential of PDE5 inhibitors for treating subclinical cardiovascular diseases. However, they are contraindicated in patients using organic nitrates, and they are avoided for whom sexual activity is inadvisable due to underlying cardiac conditions. Sometimes you may notice that PDE5 inhibitors are not working well or have failed in some of your patients. These patients may be either pseudo non-responders or real non-responders. Before concluding this failure, you have to apply these items written in this box or in this table. These include incorrect dosing, relation to food, unrealistic expectation, hypogonadism, lack of sexual stimulation, uncontrolled comorbid risk factors, and diseases. These are some of the patient's expectations and the appropriate responses to these expectations. I will not go through all of them due to time constraints, but I highlighted 3 important expectations in red. So look at the first one. Your patient may ask you that he wants the pill to make him perform exactly as he did when he was 20 years old. And the answer is the goal is satisfactory sexual performance, not regaining youthful physiology. Another expectation, the pill will automatically produce an erection. The answer will be sexual stimulation is necessary. Next expectation, I will not take the pill because it causes heart problems, and this may decrease the patient compliance. The answer is PDE5 inhibitors do not cause cardiovascular disease and are safe for most appropriately selected patients. So how to rescue PDE5 inhibitors non-responders? Well, for easy memorization and educational purposes, I collected these rescue items under the title 7Es. 7Es, in line with the 7 H's I mentioned before. This includes educate the patient on proper drug use in relation to meals, onset of action, interval, and sexual stimulation. Escalate the dose to the maximum dose. Everyday dosing, continuous dosing, exchange and switch to another PDE5 inhibitor, enhance the effect through combination therapy, including 2 PDE5 inhibitors or PDE5 inhibitor with ICI or with a vacuum erection device. Expectations should be acknowledged and discussed, as I mentioned in the previous slide. The 7th E, explore and control hypogonadism, comorbidities and risk factors, and explore any psychosocial contributors. So what are the future treatments for erectile dysfunction? Why were they introduced in the sexual field? Are they effective? Are they approved? Despite the enormous success of PDE5 inhibitors, they are fundamentally symptomatic therapies. They improve erectile dysfunction, but do not regenerate nerves, vessels, or tissues, and they do not reverse fibrosis. The feature of ED treatment aims to move from facilitating erections to restoring erectile tissue. Hippocrates once said, "The natural healing force within each one of us is the greatest force in getting well." So I think this is precisely the goal of regenerative and restorative therapy. All of these therapies are proposed therapies are considered regenerative therapies, but the last three are commercially used in clinical practice. These include low-intensity shockwave therapy, platelet-rich plasma, and stem cells and exosomes. However, despite their use by clinicians in some parts of the world, regenerative therapies still have many limitations and challenges. These include different protocols, uncertain durability and long-term effects, increased patient heterogeneity, diversity of devices, no FDA approval, ethical concerns, and costs. The AUA and the EAU considered all of these therapies experimental or investigational. However, the EAU considered the use of low-intensity shockwave therapy in mild vasculogenic ED, in poor responders to PDE5 inhibitors, and in patients who do not wish to have or are not suitable for oral therapy. So could regenerative therapies one day replace the treatments we use now? Maybe. Research is moving in that direction, but it's not certain yet. So these take-home messages. Sorry. Organic erectile dysfunction is a cardiovascular warning symptom rather than a sexual complaint. So investigate systemic health, not just the penis. Most organic erectile dysfunction are driven by modifiable cardiometabolic factors. As we said, the 7 H's. Please memorize these 7 H's. So modify your lifestyle and manage hypogonadism first, then escalate rationally. Integrate, don't isolate. Sexual, systemic, endocrine, metabolic, cardiovascular, and reproductive health are one patient, not several problems. Oral PDE5 inhibitors are a safe first-line treatment, but don't forget that other modalities like ICI and vacuum erection devices are also effective. PDE5 inhibitors do not increase myocardial infarction or cardiovascular mortality and are safe for most men with stable cardiovascular disease. The major exception remains concomitant nitrate therapy. Non-response is not always drug failure. Use the 7 E's to rescue the non-responders. So optimize use, address psychosocial issues, and manage expectations before declaring failure. Regenerative therapy for organic ED represents a promising therapy. However, conclusive high-level evidence is lacking. The future of ED management is not simply choosing the right drug. It is identifying the right patient, the right cause, and the right multidisciplinary intervention. And please remember that sometimes the penis whispers what the heart has been trying to say for years. Wise clinicians listen before the heart screams. Thank you very much.
Thank you, Dr. Mohammed. Excellent presentation. Thank you for all the speakers now. I request our distinguished moderator, Dr. Rupin Shah, to come forward and conduct the interactive question and answer session.
First, a very big thank you and congratulations to the speakers. We have had excellent talks, very crisp, very practical, very relevant. We are kind of running out of time, so I'm going to have just one question for each speaker based on what we've received in the chat, and then we will summarize the key take-home messages. So we start with the first speaker, Rosella. Great talk, as always. The question that was put in the chat group was that you show some evidence that antioxidants help, but the guidelines are still equivocal about using them. So how would you identify the subgroup of patients you might want to treat with antioxidants? Is it based on their clinical etiology, or would you base it on investigations like ROS or STF?
So both. Thank you for this question, first of all. But so I would characterize the patient from a microbiological point of view, and I would both task exams like culture of the urethral swab, as well of the semen, as well as for the semen sample, and of the female partner as well. And I would visit him also and do the ultrasound to detect any US signs of infection or inflammation. And if I find any infection, I first treat it. And then I check, for example, the morphology. If there is nothing, then I can prescribe antioxidant. Similarly with varicocele, of course, not all degree of varicocele, but for example, bilateral, high degree varicocele, this kind of with, for example, or monolateral with testicular asymmetry, they may respond poorly to antioxidants. Also, I would characterize if I don't find anything. So in case there is nothing on the clinical assessment or on the microbiological point of view, I would ask for semen spore DNA fragmentation and antioxidant parameters, and then I would prescribe antioxidants if I find an abnormalities of this series. So this is how I would manage these patients.
Thank you, Rosala. So,
and of course, sorry, I would add that lifestyle plays a role too. So think about smoking or obesity. These are sources of oxidative stress. So it's important to counsel these patients to reduce the sources of oxidative stress.
So it is indeed a comprehensive evaluation based on the etiological factors, some investigations, and then also the sperm DNA fragmentation. Thank you very much. We move on to the second talk. Again, a very comprehensive talk, as always, by Dr. Vidi, who leaves little scope for questions. We don't have a question, in fact, in the chat for you, Vidi, but a clinical situation. We get some men who don't respond to dapagliflozin or to monodrug therapy. They're the really tough ones. You did mention combined pharmacotherapy. So can you describe the combined pharmacotherapy you would use in a really tough case where monotherapy has not worked?
Yeah, so thank you for your questions, Dr. Rupin. So I think the premature ejaculation is quite common in our urologist clinical practice, but sometimes we have a problematic to treat. But yeah, as you said that usually if we use the pharmacotherapy like a monotherapy, like maybe a dapagliflozin with the on-demand, we cannot use, the effective one. But also we have to, the basic one is we have to make sure that this type of the premature ejaculation is what kind of the type. So is it true premature ejaculations, which is maybe the acquired or maybe the lifelong PE, or maybe it is only just like a premature ejaculation like the ejaculatory dysfunctions. So it is like a subjective premature ejaculation and also the variable premature ejaculation, which is maybe like is it situational. Usually the latter is usually we can just only use the reassurance, the education, also the behavioral and also the psychotherapy without the pharmacotherapy. But for the true premature ejaculation with the types of like the acquired PE and also the lifelong PE, it's quite complex, and we should maybe the first one is we should identify the comorbidities or maybe the risk factors like the ED. So maybe if there is like the ED, maybe we should also use the combination with the PDFF inhibitors. But if it is like a lifelong PE, usually we the first line is we use the pharmacotherapy. So because some mechanical or maybe the pathophysiology is because of the nerve dysregulations. Usually we can do with the daily and also the on-demand use of the combination of therapy. So basically, as I mentioned before, that if we there are two types of the SSRI, the daily and also the on-demand. Usually the on-demand SSRI is more recommended because of the side effects is not quite great, and because maybe not very frequent sexual activity, and also the health increase very realistic. But usually, if the on-demand is not enough for the SSRI, we can also use the daily SSRI, because usually we can also recommend the daily SSRI if the patients sometimes they want the greatest ejaculatory delight. So we can also combine with the daily SSRI. But we can see that so many types of the pharmacotherapy for the SSRI. So I think, and some maybe like some countries like in Indonesia, we don't have like a dapoxetin drugs. So I think we can just adjust with our drugs that are affordable and feasible in our country. So maybe we can combine with daily and also the on-demand. I think that's my answer, Dr. Wipin.
Thank you, Dr. Vidi. There was another question, unmarried man with P, but I think we don't have the time to take that. Marlon, someone just put up a question, again, a wonderful talk, thank you very much, that when would you consider or what would you consider doing for a recurrent varicocele? When would surgery be indicated and what kind of surgery?
Hi, Dr. Rupin. Good day. So for recurrent varicocele who underwent already microsurgical varicocelectomy, you should take note that a poorly done microsurgical technique will only will not give benefit for this set of patients, so will get harm. So, but in cases of recurrent varicocele, one of the treatment options is one can redo varicocelectomy, but it imposes a technically challenging procedures. Other treatment options would be like embolization, which can offer, although the benefit is not that significant with regard to the improvement of the sperm parameters and reproductive outcome. And if there is still no improvement of the sperm parameters and reproductive outcome with recurrent varicoceles, other treatment option would be referral to a reproductive specialist who will be performing assisted reproduction.
So, question coming back to the earlier part of your talk, where you said the indication for varicocele surgeries impaired spermatogenesis and infertility, or a normal conventional semen parameter with elevated STF. But often clinicians have young men, maybe married, maybe not, normal semen parameters, normal sperm DNA fragmentation, no evidence of testicular atrophy. In such cases, is prophylactic varicocelectomy recommended, or should one just monitor and wait and watch?
If there are a relatively young couple, I think observation could be an option, because as we all know, the result of semen analysis is highly variable. It can change over time. And for those patients who are relatively young, I think an option of observation and trial of natural conception is still a valid option.
So we need not worry that it's going to be progressive and the sperm will disappear. Thank you
Yeah.
very much. And we had
Thank you,
a
Dr.
very informative and practical talk by Dr. Norman. Thank you very much. You touched upon intracavernosal injection as a second-line therapy, which of course refers to home self-injection, but you didn't expand upon that. So could you perhaps talk a little about the patient who has failed a PDE5 inhibitor, multiple attempts, different drugs, and now does respond to an intracavernosal injection? Do you put them on a home self-injection program? How do you implement this, and what is the expected outcome?
Well, thank you for the question, but it depends on the patient himself. If he can manage doing self-injection, then you can discuss this with him. And first of all, you have to do a test, a trial in your clinic to adjust the dose, so as not to enter into priapism. Then you have to teach him how to do the self-injection. And you will tell him to do this test in front of you, how to do it correctly. Then if you are sure that everything is okay, you will give him the recommended dose that was tailored by you in the clinic. And at home, he can use it before the intercourse. But you have to give him many recommendations that if at any time feels that there is a prolonged erection or he will enter into priapism, he should go to the ICU, to the hospital, or to call you for this. This is very important.
So how
And
common do you
at
see
any time,
priapism in these patients?
according to our experience, not too much, but it is a serious side effects, really, because some patients, they do not get instructions and they come back to you in the next morning. And after what? Already the fibrosis includes all the penis. It is a very serious side effects. It is not too much, but it happens. So it's worth mentioning this and stressing on the side effects of the ICI.
Well, thank you very much. I'm sure we could go on and on with our questions, but we've run out of time. So very briefly to summarize the key messages from our four brilliant speakers. The first talk on antioxidants highlighted that there is evidence that it helps clinical pregnancy and live birth rate, but the evidence is still very low quality, and therefore, in fact, the guidelines are still not strong about recommending antioxidants. As clinicians, however, almost all of us use it. So perhaps the take-home message here could be that not every male should be given antioxidants blindly, that there's no one antioxidant which is superior to the other. But in those patients who have risk factors for increased oxidative stress, the obese patient, the patient with a genital infection, varicocele, exposure to toxins, maybe those are the ones where antioxidants would be justified, even if one has not measured the ROS or the STF. Of course, if the STF is elevated, antioxidants are part of the recommended therapy. Coming to P, a very important point that was mentioned is that the definitions given by various societies, 1 minute, 2 minute, 3 minutes, are okay for research purposes, but in actual clinical practice, you may have patients who are lasting maybe more than 3 minutes, but the couple is dissatisfied. So the diagnosis is really clinically based rather than by a rigid time. And the treatment options are multiple. Sometimes simple measures will work, but sometimes a combination of different measures, the psychosexual therapy, the topical anesthetic, the oral on demand, plus the chronic medication, all may have to be used in varying combinations with or without an erectogenic drug to get the best result. Coming to varicocele, we've had all the pros and cons discussed. By and large, we need to bear in mind that not every varicocele needs surgery. Many men will be normal despite the varicocele. Many men with impaired semen parameters and a varicocele may achieve a pregnancy despite the varicocele if the wife is young. And of course, many men may not improve even after the varicocele is corrected. So it remains one of the most common correctable factors in male infertility, but we cannot blindly operate everyone the moment we diagnose a clinical varicocele. And finally, coming to organic ED, very important point that Dr. Noman made, and that is a distinction between a risk indicator, a risk marker, and a risk factor. Because of all the hype regarding cardiovascular disease and ED, many patients and physicians automatically link any ED means cardiovascular disease, and was so nicely pointed out, it's a select population, the age group 40 to 60 with new onset vasculogenic ED is the population where that ED is a strong marker for possible cardiovascular disease and should necessitate a cardiovascular evaluation. And the other important point to bear in mind is that PDE5 inhibitors are safe, not only in men with hypertension and diabetes, but even in men with stable angina. And therefore, physicians need to be confident about prescribing it and need to reassure their patients. So thank you very much for our speakers and to the audience and to the organization. And we hope to see many more members from Uzbekistan and the neighboring countries joining GAF and participating in the various research opportunities that GAF offers. With this, I hand it back to Ashok for the final goodbye. And thank you and good night to all of you.
Thank you very much. And first of all, I want to thank our speakers who have done an outstanding job, and they worked very hard over the last several weeks to put this program together. They should be congratulated for their brilliant presentations, which we are very proud. And I hope our audience have enjoyed this online presentation. Dr. Rupin Shah has done a marvelous job putting everything together and creating a take-home message that will resonate and stay with you even after this program. And I want to thank our colleagues who really engineered this program, both Dr. Hiva and Daniela. And I want to thank our collaborating colleague, Dr. Aziz Bek, for supporting this and for advertising this program. I think this was a phenomenal program, and I'm very happy that we were able to execute this program brilliantly and on time. So with so much material that we have discussed and delivered today, and I hope will be of use to all of you. And I wish you a beautiful day, beautiful evening or night. So thank you very much. This program is officially now closed.